Yeah. Good afternoon, everybody, and welcome to the final plenary of the conference. I don't know about you, I'm pretty dead on my feet, but I think this session will keep us all awake. I'll just quickly introduce the moderator, Josep Figueras, who is the director of the European Observatory on Health Systems and Policies and head of the WHO European Centre on Health Policy. Thank you.
Thank you very much indeed, and thank you for being here. We're very worried that with the planes and all the opportunities in Glasgow, we're going to miss some of you, so it's amazing. We're really pleased and happy at this end of the table. The session today is, as you know, that's why you're here, it's about migrant and ethnic minorities, health and inequalities. It's indeed very much at the core of what we've been doing in this exciting conference in the last 3 days, basically. Lots of the issues we've been discussing sort of narrowed down, focused down in these particular groups. In fact, there's been as well very, very good workshops, sessions on this subject throughout. This is, without needing to say that, but still I'd like to say that, is more of a topical issue than ever. Many of the, well, actually Obama is in a political confrontation passing legislation on this field of migrants. We all know about the way that the crisis, and more than the economic crisis, the austerity measures have increased the vulnerability of these migrant populations, both the regular and the irregular migrant populations. In that sense, I'm really proud to highlight, although it's not ours, but it's from UFA, of course, and the Andalusian School of Public Health, the Granada Declaration that has been distributed in your seats, that very much highlights the kind of vulnerability, the kind of impact that the austerity measures, for instance, get pushing undocumented migrants, irregular migrants to do jobs that basically are the very bottom end, irregulated, very poor conditions. It talks about as well the way that the crisis has reduced access to services. It has cut entitlements, some of that we're going to talk about later on. And it has increased the amount of xenophobia, making these populations even more at risk than before. So just to say that the Granada Declaration is here. There are already more than 100 organizations have signed it. As I said, it's led by the UFA and the Andalusia School of Public Health and the Consorcio de Salud Social de Catalunya. So I hope that you read it and you take it forward to your various forums. So what we're going to do here in the next hour or so, in the less than an hour actually, so I should go fast. The idea is to really give a sense of what are the kinds of health status of these groups, what are the kinds of inequalities, and particularly we'll bring it to the policy side, listening about the kinds of interventions to increase access, to increase responsiveness to these populations, and the kinds of policy documents at the national and European level. And for that, after the 2 excellent keynotes, we will have a panel representing 3 organizations, the WHO, the ECDC, and the European Commission that are playing an important role, and we want them to keep playing even a more important role in the health and access of these populations. So, first of all, therefore, we're going to hear Professor Raj Gopal. You all know him. He's a professor here in public health in Edinburgh, and is someone who has a key, wonderful record of analysis, assessment on this area of migrants and ethnic minorities. I don't think we could get a better keynote speaker to start with this session. And he's going to thresh out some of the issues about the health status, the inequalities gap, and talk about as well some of the interventions at work. Raj.
Chairman, colleagues, what a pleasure it is to be here standing in front of you, speaking on my favourite topic, and of course in one of my 2 favourite cities in the world, Glasgow and Edinburgh. I was brought up in Glasgow and spent much of my university life in Edinburgh. Anyway, the chairman has said you're not getting 15 minutes, you're only getting 12 minutes, so I better get cracking. You can read the title of my talk there, Reducing the Inequality Gap Using the Ethnicity, Migration and Race lenses. I'm going to take a couple of examples that are dear to me, cancer and heart disease, and try and draw some conclusions, which will end with a policy-orientated conclusion given the tenor of this particular plenary session. So we belong in a new world. This is not the world our grandparents knew, or even our parents. They lived in a world where around them were people who behaved much the way, had the same cultural values, they looked much the same. We belong to a new world which is very exciting, but this also brings its own tensions and its own challenges. And I believe that this issue of a multi-ethnic world, which is going to become a harmonious multi-ethnic world, that issue is as important as climate change. If we don't manage to achieve that, the world will tear itself apart with civil wars and other problems. Now, we know there are major inequalities on a number of dimensions. There are massive inequalities between countries, huge inequalities that relate to wealth and income. But migration status, ethnic group, and race are also three variables that are associated with quite surprising inequalities or differences. Now, I'm going to just use the concept of ethnicity. I know that not everyone is comfortable with it. I know everyone doesn't use it. For example, in most of the mainland Europe, people are talking about migrants and the concept of migration. In the North America, they use the concept of race. But in the UK and much of Europe, we're moving towards the concept of ethnicity. Now, what I'm going to try and demonstrate to you is that the inequalities by ethnicity, or one of the other related variables, whether it's country of birth or whatever, are surprising and often unpredictable. And maybe a message I'm going to leave with you is that very often the minorities may well have better health status, and we should be looking to them to answer the question, how do we improve the health of the entire population? So why do we have ethnic health inequalities in the first place? This slide gives you a small list. I've actually put it in my view, in my personal view, in rank order. Very often people, the first thing they think of is genetics. And that's the last thing I think of. It's culture, economic status, it's the environment before and after migration, it's the lifestyle, it's the healthcare utilization. And maybe, yes, for some outcomes it is important, the genetic side is important. So what am I going to do in this presentation, having given you that background? I'm going to present illustrative data on cancer and MI using the Scottish Health and Ethnicity Linkage Study. I'm going to demonstrate that utilizing ethnic group inequalities helps set appropriate public health targets. I'm going to share some experience of evaluating interventions to try and reduce inequalities, and I'm going to consider the implications for public health policy. Believe it or not, I'm going to do that in the next 8 minutes. That's not right. Oh yes, well, what are we trying to do? In a way, this slide tells it all. We're trying to move from the left-hand side to the right-hand side. On the left-hand side, we have the cover from the 1983 WHO consultation on migration and health, published but hardly known now. It's a book, it's a great book. It says everything we need to know. It shows the migrants or the ethnic minority groups in the shadows. Unbelievably and coincidentally, in the 2010 global consultation, the cover also showed the migrants in shadows, but that was not deliberate. So that metaphor is obviously very important. We're trying to move them out of the shadows into a vibrant, healthy, multicultural society. That's our goal. Now, in Scotland, we have been collecting ethnic group at the census since 1991. The census holds ethnic group plus a lot of other information on social and economic status, country of birth, and in 2011 now we also have how long a person has been resident in the country and also their language, their preferred language. We have great healthcare databases in Scotland, but they don't have ethnic group in them. So what we did, we used a probability computerized linkage method in a secure way. We actually linked the census to the health records. I think it's quite an unusual thing to do, but we've been doing it for some years and our methods are well recorded. I'm not going to go into them. Let me give you some illustrative data from this study. This is all cancers, age standardized risk ratios by ethnic group. So on the y-axis, we have the rate ratio. That dotted line is the standard population, which is the white Scottish population. I'm just going to use the terminology we've adopted in Scotland. It works very well here in Scotland. It might not work elsewhere, but it works here. There's the Scottish data. We have other white British, Irish, other white. And we have started to disaggregate the white or the majority population. We find that there are big differences between these subgroups. I've taken another example of the Indian population, and just to show you, well, what we find is that the other white have got low cancer rates, and Indians have got very low cancer rates. So have the Pakistanis. Well, that's a big surprise. They're doing better. How often do we hear that the minorities have got very poor health, they've got this and that, and they're a big problem? Well, when it comes to cancer, they're not a big problem. It's wonderful. Let's take another example, breast cancer screening. Well, in breast cancer screening, the white Scottish population is doing better than any other population, and every other population, especially the Pakistani population, have got more did not attend when it comes to breast cancer screening. So, when it comes to cancer, doing well. When it comes to some preventative service, not doing so well. Let's take first myocardial infarction, its deaths and hospitalizations. Similar chart. Other white British doing very well. They're mainly professional people living in Scotland, good jobs. Pakistanis are not doing well. Chinese are doing incredibly well. They tend to do incredibly well on a wide range of things. But what's the message? The message is, the Scots are notorious for being top of the league for heart disease. A migrant population comes into Scotland, they actually beat the Scots at their own game. That's a bit worrying when it comes to heart attacks. Chinese, on the other hand, they're just as in the same socio-economic status as the Pakistanis. They came around about the same time into Scotland, and they somehow or other have avoided all these heart attacks. And these are not just statistical artifacts. We've looked at this very carefully. When you adjust these data for social and economic standing, when it comes to the other white British, they get close to the white Scottish line. You can explain most of that difference using socioeconomic indicators. But this difference cannot be explained by any factor we've looked at. So, one of the things we're interested in, well, actually, what about, you might say, well, how does the healthcare system in Scotland cope? This is the outcome after you have your heart attack. You find actually the only group that's not doing so very well is the Chinese. The numbers are small. These are 95% confidence interval bars. But this has been shown elsewhere in the world too. Chinese don't get many heart attacks, but when they do, their survival is lower. By contrast, the Pakistanis, they get a lot of heart attacks, but their survival seems to be a little bit better. We know that the confidence interval for women does not go through the reference line. But it looks like the health service in Scotland is actually managing these people pretty well once they get their heart attack. Now, one of the most important explanations as to why South Asians and Pakistanis have got a lot of heart disease is because they have a lot of diabetes. So, what can we do about that? Well, we ran a project here. It's one of the first community-based randomized controlled trials to try and prevent diabetes developing in people at high risk of developing diabetes. It's a bit like the Finnish diabetes prevention study. It's a bit like the American-US diabetes prevention study. Well, we sent dietitians into the homes of people at high risk 15 times over 3 years. And in the control group, we sent dietitians into the home 4 times. So it's a very complex trial. It cost many millions of pounds, and it's been published now, December 2013. So I've got no time to tell you the detail, but I'm going to give you the key result, which is weight loss. And you can see that in the control group, they get 4 visits. In the first year, they take off a little bit of weight, but by the end of the trial, despite those 4 visits and information, they've put ½ a kilogram on. In the intervention group, the 15-visit group, they took off a kilogram, and they kept the kilogram off. At the end of the 3 years, there's 1.6 kilogram difference between the 2 groups. Now, that's a very small difference for a vast cost, but it's the only time in the whole world, anywhere in the world, it's been shown that South Asians can lose weight and keep weight off. No other trial has been able to demonstrate this over a 3-year period. Well, that's waste, and it's exactly the same results. So now I need to start to conclude. I've got about a minute left. So what's the insights? Well, the insights are that ethnic variations are larger when using the ethnic group variable than the country of birth variable, presumably because there's less misclassification. I haven't necessarily demonstrated that, but we've shown this using this study. There are important inequalities in every outcome we've looked at, and we've looked at about 20 outcomes so far, and we're about to start studies to look at about another 20 outcomes. The inequalities are not predictable. The common generalization of disproportionately poor health in ethnic minorities is a seriously flawed concept, and we must get that right. Even in the most health disadvantaged group, e.g. the Pakistanis, there's good news. For example, in cancer, I've shown you in breastfeeding, their breastfeeding rates are much higher. Little is known about the mixed ethnic group. We're providing some of the first data in the world on the mixed ethnic group, but we're finding some cause for concerns. Ethnic variations do reflect socioeconomic differences amongst the white subgroups, but not amongst the white and non-white subgroups. And we're beginning to develop some experience of developing and adapting interventions to do something about these inequalities. So, what's my conclusions in relation to policy? First, we have to integrate the social determinants and disparities, ethnicity, race, migration agendas. They've been going in two different directions, which is a great pity because there's a lot for the social determinants people to learn from us, and of course, there's a vast amount within the social determinants agenda that we should be incorporating within the agenda we're working on within the migrant and ethnic health subgroup of UFA. Interventions to reduce inequities and inequalities in these groups will benefit the whole population's health, not just the minorities. We're not doing this work to benefit the minorities, we're doing the work to benefit everyone. How does it bring about these benefits? It brings better legislation and policy, and that arises from social justice. Most of the equality legislation has started with race relations legislation. That's where it starts, wherever you look in the world. And then people accept those arguments and they say, well, what if it's good for racial minority groups or ethnic minority groups, it's also good for women or the disabled. That's where it started. It strengthens epidemiology and public health in ways I hope I've demonstrated, and it helps to improve interventions in healthcare, and I've demonstrated that through the PEDOSA study. So, implications for public health policy. European information and health systems and initiatives need to work harder on these inequalities that I've demonstrated. Such work will improve the health of our entire population, and it should become central to European public health and healthcare strategy. Thank you, colleagues.
Thank you very much, Raj. You were very effective with your 12 minutes. You make them last, and you communicated extremely well. Well done. Thank you very much indeed. Important, but not disproportionate. I wonder whether that applies to systems as well as the Scottish one. I think we have to learn about the Scottish Health Services as well. You raised a couple of points I will put in the panel about better information, and certainly a core element that comes from the other presentations as well is that interventions in this group, it's not just for this group, benefits the whole of public health. I think that's fundamental as well at the time of communicating that to policymakers. But Marine Buissonnier is well known for all of you in this field as well. She is the director of the public health program of OSI. I admire profoundly this group. Part that they were partners of the observatory years ago, but in addition to that, they are really working on the discriminated populations, the more vulnerable populations. They're at the cutting edge of innovation, so the big agencies learn from them, and they always think out of the box. They are not afraid. And Marine is going to talk to us about an area they have excelled, is working with the Roma population, what kinds of interventions they do at the community level, at health service level, to increase the access and the health status of this population. Marine.
Many thanks, Joseph. And is the microphone working? Yeah, great, thank you. And many thanks for the organizer for putting, for the first time, I believe, in a plenary, the question of Roma health. So I'm very grateful to all of you for that. When I began preparing my notes for today's presentation, my natural impulse was to review data of inequalities in health pertaining to Roma, and in particular in the wake of the economic crisis, and in particular in the context of what the austerity has fueled in terms of particular choices in health and health cuts. I considered the most recent and most compelling data produced, knowing we only have a few and they are imperfect, those data that would convey the inequality in health faced by Roma communities in Europe and might move us to action. I figured that I should put forward the average age at death between Roma and non-Roma in Romania, 52 years and 68 years, respectively, in 2013. That maybe we would be worried by vaccination rates. Just half of the Roma population in Slovakia has received some sorts of vaccinations. And I was also reminded by Dr. Jean-François Corti from Médecins du Monde earlier this week on Thursday that in Roma settlements in France, only around 30 to 40% of people are vaccinated, and sometimes lower than 10% in some areas. I figured some of you might be shocked to learn that 30% of Romani women in Romania report never having had a gynecological examination, twice as high as the general population. And I imagine that in a room such as this one, those statistics, known by many, new to a few, would in and of themselves tell the story of marginalization of Roma people affected by social exclusions and violation of health rights. And I thought that would move policymakers. I imagined I would add to the call of ethnically disaggregated data to inform policy, building on the groundbreaking work that has been done by the European Roman Rights Centers, without whom such statistics would even be fewer. But I realized this was not the story I wanted to tell you. The story I wanted to tell was another one, less known, which I found in contrast to be much more inspiring, though seldom told. This is the story of Roma communities devising and leading solutions that have and can lead to better health and rights for Roma and beyond. And I will share with you today 3 examples. Yesterday, we had what I believe was a first at a European Public Health Conference, a poster without an author. The presenter, Teodora Krumova, whom you're seeing here, who is from the Roma NGO Amalipe in Bulgaria, credited the Roma community in Bulgaria with the research. She was only the messenger. Throughout Europe, Roma communities have recently embraced community-driven inquiries, community monitoring, and applied budget work, which have succeeded in holding local officials to their stated commitment in the health sector. In Bulgaria, national legislation has been drawn up to address inequalities, but implementation of this law has been close to zero, to quote Dejan Kolev from Amalipe. Although the legislation sounds good on paper, there has been a lack of financial and administrative support for the proposal. Complicating the situation is that devolution of health budgets has left health inequality largely to the discretion of local authorities who are not accountable to the most vulnerable. This was until recently. In 2011, Amalipe decided to put Roma at the heart of holding local authorities to account for the delivery of health services, not just for Roma, but for the entire community. Following a model first proposed by Abhijit Das of the Public Health Institute in India, Amalipe developed a system to enable communities to monitor healthcare services themselves and to carry out their own research into their own health and how local services met or failed to meet them. How did they do it? They established local volunteer clubs that brought young people, women, and informal leaders together with trend moderators to discuss health issues. Together with Amalipe project team, these community organizations conducted survey of the health of Roma women and their use and knowledge of healthcare services. And the challenges found, of course, were not surprising. Food insecurity, inability to afford medicines, discrimination from medical staff. The surprising part is that because of the way the data was collected by communities within the view of local authorities, the impact was almost immediate. Amalipe project team shared their result with the wider community, with the local municipalities and other institutions in charge. Action plans for addressing the harshest problems were designed. The community has been undertaking monitoring every 6 months to assess progress since. And I'll just give you 2 numbers. Between June 2012 and June 2014, in some of the municipalities where Amalipe has been working, Roma women who could identify their local primary care physician increased from 83% to 94%. Reports of illegal payments during the same time at both the GP and hospital went down dramatically. Regular medical checkups for the children almost tripled. In public health, we are used to a rather large time lag between evidence and implementation. We operate on a traditional policy cycle whereby the academically produced evidence is then translated for policymakers, often by elite NGOs, and churned through the political process. In this case, the link between the evidence and the action was more fluid, more seamless, and the leadership of the community and their direct and repeated engagement with local leaders has the effect of translating community-produced evidence into change, not only for Roma, but for the communities at large. My second example comes from Macedonia. In 2009, the Macedonian law was amended to provide universal health insurance to its citizens. But those Roma who live in slums or temporarily dwelling still found it difficult to access health care. And they often lack the documentation necessary to apply for health insurance benefits. In a study carried out in 2 Roma communities in 2011, the NGO essay found that 76% of patients were unable to obtain care. Again, this feels neither new nor surprising. What is surprising is the community solution once again. In those areas, Roma community did not simply engage doctors, nurses, or even Roma health mediator to address these gaps. Rather, they have engaged paralegals trained from within the communities. SA has worked with 4 Roma community-based organizations in the Roma community of Shutu, Orizari, and Delchevo to train 12 community paralegals on human rights and the structures of the Macedonian healthcare and judicial systems. Romina, whom you see on this picture, he's one of them. As my colleague Sebastian Kohn describes, the paralegal conduct door-to-door outreach, hold office hours, listen and provide advice, and in some cases, they intervene by accompanying clients to local authorities or clinics where they negotiate resolutions to disagreements, lodge complaints, demand remedies for violation. They also help many Roma obtain personal identification documents without which they cannot get health insurance to subsidize their care. Between 2011 and July 2012, more than 587 people benefited directly from the paralegal services provided by this Roma community organization. The intervention worked. To give one example, other than the one on the slide, in a village in Eastern Macedonia, paralegal helped villagers successfully advocate for a local vaccination center to be obtained to serve the area, and they are in the process of applying for rural health area status, which would give the village access to an ambulance. Even government actors, such as the regional unit of the Macedonian Health Insurance Funds, now regularly call on those paralegals for help in overcoming language barriers and issues with personal identity document. My third and final example is actually sitting in this audience. Since 2008, over 1,000 young Roma have enrolled in medical and nursing school in Bulgaria, Macedonia, Romania, Serbia, thanks to an enriched scholarship program supported by the Open Society Foundations. When the program was started, you could count on your hands the numbers of self-identified Roma medical professionals in these countries. But these students are changing the reality from within. Not only do they represent the next generation of doctors and nurses in their countries, but they also are contributing to public health research and knowledge, and in many cases, presenting their findings in this very conference. On the right-hand side, meet Corina Stanciu. She's doing her oncology residency at Carol Davila University of Medicine in Romania, and she's contemplating a career in palliative care. I hope you had the chance to attend a poster presentation yesterday about access to healthcare for vulnerable Roma populations. On this next picture, giving a big hug to my co-panelist, you can see Gabriela, also a student at Carol Davila University, who presented on arterial hypertension among Roma people, Madalina, who presented on reproductive health and sexual behavior among Roma community in Romania, and Pepa, a student at the Medical University of Pleven in Bulgaria, who presented on the impact of prematurity on demand for health and social services. Now, after her presentation, Pepa said, "For the past 2 years, I have presented posters on Roma issues. This time, I wanted to present something for the entire community." These students are challenging the narrative that Roma are only users rather than providers and leaders of health interventions. When flood hit Serbia this summer, among the first responders were Roma medical students. They were met with surprise by some of the non-Roma residents. "Why are you offering me services? I'm not Roma, but I'm a doctor and you look like you might need help," was the response. Those medical professionals are an incredibly powerful new generation of Roma who are challenging their own community's internalized view that one of them cannot undertake university studies and aspire to be a medical professional. Their fellow students' view that a Roma can be a successful student. Their professors and mentors' view that a Roma can be a doctor, and their patients, and ultimately society's view. One by one, they are changing the Roma narrative. So what are my recommendations? Well, I think what these three examples, what these three lines of work vividly illustrate is that supporting communities to lead and participate in human rights-based solutions that improve their health opens a different path, one that could possibly take us out of the infertile circles of failed investments and invisible results. They also illustrate the new thinking and imaginations that are needed to address some of those intractable problems, such as the gap between policy and implementation, the social determinant of health, and the prejudicial belief about ethnic minorities. And that this new thinking and imagination comes from within communities themselves. What are the policy implications? Well, I'm sure we'll talk about it in the debate, Joseph, but three. I'll put out three. The decade on Roma inclusion is expiring next year. Many will make a scathing assessment of what it has delivered. One of my workshop participants on Wednesday, Marianne Ursel of Carousel, said, we have a lot of money, a lot of programs, but we see no improvement. Could it be that we are looking in the wrong places? Communities are excellent judges of whether national and European policies are delivering results for Roma. The European Commission and member state could think of making community-based monitoring an integral part of the implementations and evaluation of the national Roma integration strategies. Obtaining information from within communities through systems established to assess accessibility, affordability, and quality and appropriateness of the health and care services provided to them. A second one I would put out is data collection. Even though I have not focused on quantitative data today, it remains true that policymakers cannot address the growing inequality gap without ethnically disaggregated data. Lack of data poses obstacles to monitoring success or failures of policies, and it also prevents us from dispelling from some of the myths that are still out there. There is still strong resistance to disaggregated data in some states, despite the absence of an EU prohibition. So I would like to call on the CDC and WHO and the others to encourage European countries to collect disaggregated data through exchanges of good practice, dissemination of information, and support for pilot projects that can serve as models. And I think we were reminding this week that the United Kingdom is actually well placed to share best practices. Finally, last and most important, I would like to invite commissions and member states to scale up promising health inclusion practices and fund such initiatives adequately. We should no longer satisfy ourselves with the successful and much praised Roma health mediator model, which always continues to be presented as the only best practice in this field. All three interventions I mentioned today, community monitoring, paralegals, and Roma health scholarship, are worthy of considerations. And I would like to encourage commissions and member states to evaluate and document this creative intervention as ways of adding to the toolkits. In conclusions, I would hardly be the first to quote Winston Churchill, who said, "Never let a good crisis go to waste." It is bad enough that we have allowed the European crisis to increase health inequalities among Roma and other vulnerable groups. The real mistake, however, would be to fail to harness the imagination and energy of communities in leading solutions to these problems. Communities know what works for them, and they know how to measure that. It would be a tragic failure of our system if we failed to capture and support that for the benefit not just of Roma, but of everyone.
Indeed. Thank you very much, Marine. That was amazing. That was very good. I think all these words earlier about inspiring, interesting, cutting edge are understatements after this presentation. I will not echo them because they're very clear. We're very clear there. It's all about empowering these communities. It's not about more intermediaries, actually, but getting them to do the work, collect the data. But as well, you put some clear challenges to the colleagues here joining us today and to the agencies I'm going to refer now immediately. So we're very lucky to have here The three key agencies have been working at European level, or three of the key, most important ones, agencies that have been working on the issue of migrants and ethnic minorities. So I'd like to introduce Carl Ekdahl from the ECDC. He's Director of the Public Health Program and Communication. Then we have Isabel de la Mata, who's Principal Advisor in public health within the DG Sanco, and Santino Severoni from the WHO in charge of the Office of Health, Development and Economic Investment, and of course in charge of the program of migration, putting all sorts of very exciting activities ahead. We're talking, the first round perhaps it should be about the health status of these populations, the inequalities, building on the presentation of Raj earlier. Carl, the xenophobia, the discrimination is very much fueled by this sense that the migrants bring all these nasty diseases. You know, we read that in the press. The first thing they do when they find a migrant in some beach in the south of Europe, what they do is look where they have Ebola, HIV/AIDS, TB, all those kinds of things. So what are the numbers telling us on that, really? I mean, you guys have been looking at that very effectively.
Yes, thanks, Joseph. I think there are a lot of myths. And I think you very eloquently talked about these myths, the myths that while with opening the borders, we will have a flood of migrants that will bring communicable diseases and affecting the European populations. So just let me give some facts instead. First, I think it's important to recognize that most of the migrants coming are a healthy population. And it's first when they are arriving to Europe and they are getting in unsanitary detention camps. And there they are really exposed to communicable diseases. After that, they are going out in the communities and this lack of access to healthcare. It's in a very bad settings where this goes on. Of course, the panorama of diseases are about the same as in the countries they are coming to. So for the two big diseases, tuberculosis and HIV, we see that of course, that when they are arriving, they are carrying the same prevalence as in the countries. So in the low prevalence countries of Europe, a quite high proportion of the cases, both for tuberculosis and for HIV, is seen in immigrants. All over Europe, for both diseases, it's about 1/3, but in some of the low incidence prevalence countries, like the Nordic countries, like Luxembourg, it could be for the two diseases up to 75–80%. And of course, these are figures that are quite visible. But how does this in any way affect the epidemiology within the native populations of Europe? And I would say that it does so in a very small extent. What we see is that after the arrival, there is a transmission of these quite serious diseases, but that transmission is mainly within the ethnic population, within the migrant groups itself. And here there are really problems. If we are taking HIV, in the United Kingdom, in 2004, only 24% of the HIV was in infection after arrival, and that has now increased to about 50%. And policymakers and decision makers are often not aware of that, so they fail to design the programs to acknowledge the fact that there is an ongoing transmission within these groups. Looking at HIV, the other big problem is the late diagnosis, and that we see in many other risk groups, but especially in the migrant groups. So the lack of access to healthcare means that these groups are not diagnosed at an early stage, and this means that they are not getting antiretroviral therapy, with increasing morbidity, increasing mortality, and then of course also the risk of spreading the disease even further. So I think that these are really the two main conclusions that spread within the migrant groups: lack of access to healthcare and late treatment.
It seems to me that perhaps as agencies, as experts in this room, we should be much better at communicating to the press and the people. Because what you're saying here, which is interesting because of the numbers, it's not surprising us, perhaps. But the debate out there is not that way. And the debate out there affects very much the policies and the politics of our leaders. I was listening Question Time this week, talking about the migrants and the politics in this area, in this country, and it was frightening. It was not talking about health, but other areas, some of the messages that were put by politicians on that table. So I think one of the lessons, perhaps, is how we communicate that better. We make them sick, Santino. Clearly, it's not that they come sick, but we make them sick. I mean, what is from your experience, you've been working, supporting those migrants arriving in Lampedusa, arriving in the south of Europe. WHO has been pushing member states to provide services in south of Spain as well for these very often undocumented or irregular migrants would be the way to call them. Are we making them sick then in that area as well? I mean, is it what Carl was saying, the lack of services? What's happening there?
Certainly, I fully agree with Carl's picture. And certainly it's true that we could do better. I also do agree very much with you that paradoxically, we end up to be not very ready in proper communicating the public health aspects related to migration. So we are public health specialists, but we allowed other stigma or the political arena or the political polarization, migrants yes or migrants not, to take over the scientific evidence or the debate about the scientific evidence. Discussion about Ebola and migrants is every day on TV in most of the countries of our region. But it's also true, we must recognize that we fail to explain that even if migration is a bridging phenomenon between two different countries with probably two different health profiles, probably also with a different prevalence of certain diseases, actually we do play a role because we need to keep in mind that migration is always accompanied by a phenomenon of urbanization. And migrants, unfortunately, are likely to be candidate to end up into not very prime area in our urban city or urban area in our cities. And the consequence is that poor housing, poor living conditions, the attitude to quickly catch up with a Western lifestyle to somehow feel integrated, feel that now you made it to a new life, actually can be also a trap because can expose these people to traits and risk that they are not always addressed by the government, by the health sector, and
on the health, let me push you. That's very important. In a minute, I'd like to talk about the monster of Loch Ness and sightings of it, of health policies. But at this stage, on the health services side, what are the member states doing with entitlements to the benefits, to the access to these particularly undocumented populations?
Well, for what I'm observing, certainly we are witness of a moment where things are changing. And unfortunately, they are not necessarily changing for the good, or in some cases, yes, but the financial crisis of these last years didn't help us to really see brave governments like the act that you were mentioning before in US of Obama to really say the truth, that probably the opening the door to a better access to services and to prevention for those people would be cost-effective measure. And I was sharing with you a story, probably that you were referring to before. We start to look into the situation in Sicily. Sicily in the last 10 years has been receiving about 200,000 migrants through Lampedusa. It was a special context because we was managed the possibility to somehow screen them, to observe them. All of them, they were coming from the same place, entering the same place. And this year has been certainly special because 150,000 people arrived in Sicily. So we've been working with the health authority to set up, because there was a fear of Ebola, because there was a fear of communicable disease. The media was really after us and after government. So we need to set up and prove that risk was not there. So we organized a very successful, I would say, screening on board of the ships, collecting people at the rescue at sea, and then the clinical observation and screening was continuing once they reached land. And what we've been observing looking into this data, first of all, the communicable disease risk was actually close to nil or minimal, absolutely endable by the health authorities. But looking at the past, at the last 10 years, because the law in Sicily says that the government actually has a positive attitude, if you have a problem, you're entitled to a code to access to emergency care and secondary care if this is necessary. So what happened that the entry point, the gateway to the access to services is basically the hospital. So we observed that a lot of patients that were hospitally referred and treated, even if unnecessary, but because that was the way how the system has been settled. So looking at the figures, we realized that there was an overutilization of the services rather than what could be the normal practice. And when we look at the economic figures in 2014, 150,000 people arriving in Sicily, the screening and the starting with triage and screening and clinical screening of migrants has been costing for the regional health authority about 15 million euro, upfront to a spending which is close to 6 billion euro per year for the healthcare services. So all this service was covered without any additional budget request to the central government, but utilizing the resources available in the field and utilizing the healthcare facility and personnel available on the field, trained and prepared for that.
It's very interesting because by trying to reduce, I mean, there's been a lot of debate these days with the Luxembourg Court of Justice ruling about welfare tourism, by trying to reduce the health tourism or the health service impact, the budget impact of this population, we end up spending twice because we end up providing emergency medicine but not giving what is cost-effective as primary health care. That would be another message perhaps from your agencies to make very clear to the policymakers that actually given access to primary care would save you a lot of money ultimately, because when you're dying outside the hospital, you'll be picked up at a very expensive cost. Isabel, continuing talking about the health status of these populations, and particularly being inspired, I'm following Marine's presentation. One of the areas that the European Union has done well, very well, pushing has been the health status of the Roma population and their problems. You had a report, you published a report that Marina made reference to. Can you tell us a bit more on that?
The Roma Health report that was published in September. And even if there are some issues with the report, I mean with the technicalities, because there are not many data, most of the data come from surveys, specific surveys, small studies, the quality is different, because one of the issues, and it's one of the issues that summarize the report, is that the lack of data, routine data, because in many member states the possibility of collecting data in the ethnicity is forbidden. It's not only that it's not collected, it's that it's forbidden by law. Because, well, we still have some souvenirs of issues 20 years ago, 60 years ago in many member states, and so this possibility is not politically possible. But even without those issues, the report that we publish shows that the Roma population in general suffer of has worse health than the general population, that suffer from greater exposure to risk, socioeconomic risk and environmental risk, because the housing is worse, the unemployment is higher, the education is lower in general. I mean, that the lifestyles are worse than the general population, that also they have poorer access to primary health care, preventive health care, that even the health, as a consequence of all that, the health outcomes are poorer and the morbidity is higher. The chronic diseases also and have shorter life expectancy. So in general, they are doing worse in all the aspects. As a result of the economic crisis, this report shows that the health status is deteriorating, as could be normal. I mean, expectable. In many of the member states. So this is the big summary for specific issues. What for example, the consumption of tobacco is higher. The life expectancy, I have already said that even if in some member states is 20 years less than the general population, the vaccination status of the children has already been mentioned, is lower. We have had example on some outbreaks in some member states that have tackled mainly just Roma children, and the prevention in general is lower. So we have an issue. In general, even if we don't have complete data, those data that we have show that, that we have an issue. And we have already been some years now with the Roma strategy in general that has 4 legs, and one of those legs is health, the others are employment, education, and housing. Even if the health one has less weight in the strategy, because it's true that it's also a consequence of the other 3 ones. We are dedicating some efforts, and also the structural and investment fund can be dedicated for that. But for that, the member states have to use the funds, and that has to be used at local level. We have good experiences. Marine has already done.
There is money from them too. I'm sure you haven't taken advantage.
Yeah, but she already knows that the issue is that health has to compete with other policies, and that in the areas where can be used for health is not only for Roma people, because usually those same localities or regions have general population in worse situations. So it depends on the
Let me push you there on the monster of Loch Ness from the previous plenary, where there are sightings, where there's such a thing as health in all policies, what's happening. And I'd like to hear some of those. I mean, you all put determinants, of course, at the core of this problem. Clearly the problems, and some of the tweets are suggesting that already are not on the health services only, but are on police, interior, other ministries, and so on. Well, you've been recently in the presidencies. You've been involved in some of the presidencies. I mean, what happened with the very good programs that the Portuguese presidency, the Spanish presidency put in place, and what's happening now both with the Greek and Italian presidency that tackled that? You both were, and Mark, your director, was in the recent presidency discussion in Italy. Are we taking, per se, these presidencies are Loch Ness monsters, you know, are really health in all policies? This is the places where you can affect. Are we using that effectively? Are we convincing these other directors, these other ministers in the presidency to tackle this one?
Well, certainly as a WHO, we are grateful to the Portuguese presidency, because probably a big part of my work would not be here today without the presidency in 2008, which lead up with a resolution on the health of migrants. So it's an historical moment. This was followed by Spain, that gathered about 100 ministers of health from all over the world to see how they could move forward for the implementation of that. The reality is that from the recommendation of the resolution point of view, no big changes has been observed, to be honest. If we are losing the moment, if we are not using the presidency opportunity to play the right game, I don't agree. Actually, my feeling is that in these years, we've been observing really a growing of understanding, attention, debate, health sector more committed, which was not before. This almost sounds like a new in 2008. So this has been steaming and moving in these years. I think then 2014 is another historical time, because I never seen before 2 presidencies in a row having as a core priority migration in the agenda, and committing into very concrete steps into the, of course, I'm more interested about public health aspect of migration. Greece with very clear attempting to look at the screening issues, and then the Italian presidency with very strong intervention to highlight the situation in the southern part of the Mediterranean. I think we need to look at the conclusion of this presidency. If the conclusion will be providing recommendations that the next presidency can build on, well, it's going to be very exciting, because this means
we don't know that. Do you know whether it goes to council? Maybe, Isabel, what are your hopes for this presidency, for the Italian presidency, and this brought in the broad health and all policies agenda?
The council takes place the 1st of December, and then the Latvian presidency will be working in some areas that could be related to health in all policies.
For migrants, for migrants?
No, in general. For migrants, I mean, it's not like you said that the monster. I think we have the momentum in 2009, we have 2010 with the Spanish presidency, we have now, but in the middle we have been working on that. And maybe the big difference, or you don't feel that that there is so much work, because you have been always working in migrants' health, and you feel that it's not the same level in all the institutions. But before 2009, nobody mentioned migrants' health in the European Union. So something happened, and from that moment, we haven't stopped, and it's in the agenda. Now, one of the priorities for the new commission that entered in work 3 weeks ago is migration. We will see what inside migration, and we hope that that we will be able to introduce health and continue to work on that. And a related issue, as one of the ministers said in this conference at the end of October, is that at the same time, some countries have suffered from an increase of the population, even in some cases more than 15% of increase of population, and a decrease in the health budget that 20%. So they have, with 80% of the budget, they have to cover 120% of the population. And
the Greeks were saying that, I heard, no? The Greek minister, no?
Yeah, that this is very, very difficult. Was a new minister, was not the minister that made some declaration before. So
let me, and I want to go back to Carl in a second, but let me, how does that sound, Raj and Marina? I mean, are you happy? I mean, the next round, I want to ask them very briefly, what are these agencies going to do in regulation, communication, support? Choose 2 or 3 you want to put forward, information and so on. But as we're close to Christmas, what would be your Christmas sort of letter to, oh, you have a letter ready.
That's a long one.
You are all prepared, you know. He's prepared, insightful. Both of you, what is your Christmas letter to these agencies? And be nice, be nice.
Of course.
And realistic.
Christmas is this on?
Yeah, it's on.
Christmas is a time to be nice. So, dear Santa, please bring me a logical, respectful vocabulary that we can all use. To take one example, the children of immigrants are not immigrants. There's no such thing as a second-generation immigrant. It's insulting. Number 2, dear Santa, please bring me a European information system that provides some data by either ethnic group or country of birth or immigrant status, or even better, everything, so that we can actually examine things across Europe. Dear Santa, you have wonderful policies. Please turn those into costed, managed plans that can be implemented. Dear Santa, policies without monitoring are not really worth writing. Please put in a monitoring framework and an accountability framework so that managers' bonuses depend on achieving these policies that you're so good at writing. And ultimately, we need to publish the performance of the different European nations in an accessible way so that we can all see whether the countries are actually achieving the goals they've set themselves. Thank you very much, Santa.
With your permission, we're going to print out this letter and ask you all to sign. So have more power for Santa. And I think if you, the communities in public health, sign this letter, maybe we have a chance. Marina, what's your letter?
So it's hard to follow that act. What I would add. So, dear Santa, there's already a lot of money for Roma on the 2014-2020 plan. So what I really want is that the policy funding programs are designed, including from the onset, in close collaboration with Roma civil society and communities, and that, as I described earlier, community be considered as really the pathway to better outcomes, as opposed to an obstacle to be overcome to reach better outcomes. So that would be one. I would like as well in that same context that the European Commission help and use all its weight to ensure that member states include Roma integration among their operational program and introduce benchmarking in their progress reports and make these public so that we can use those. And finally, and that's something that many of us seem to want, so maybe Santa will listen, I would want ethnically disaggregated data. This is something we've been missing. We've been missing it to develop relevant policies, to measure policies, and we've been missing those to dispel the myth. So we need ethnically disaggregated data. There is nothing that stands legally in the way of us to do that. There's a lot of good practices that exist out there. So may we learn from those in the new year and make those a reality by the time we next meet next year.
Thank you very much. I trapped you a little bit here, guys, because I made you Santas. You were not prepared for that, but I think this letter goes to all of you as well. You should carry it on your letters on your pocket and show it to your ministers and more than ministers of health, prime ministers. What I'd like to do is last very few minutes because, of course, we're running a bit late. From these organizations, you're doing an awful lot of work, perhaps not meeting the Santa wishes, but, or the wishes to Santa, but you're doing a lot of work. Let me start with you, Carl. I mean, you've been supporting very much immunization programs, screening programs, and so on. Can you give us a sense a bit of the kind of work you're doing, very shortly, one after the other, before I do a final Twitter thing?
Okay, I think we are the EU assessment, risk assessment part. So our work is actually twofold. We are compiling data, and I would very much welcome a situation where we are getting the disaggregated data that you are talking about, and we would be very happy to use that also in our reports. So far, we have been picking our data from literature reviews, etc., but having that in the surveillance system would be great. So providing facts. The other thing that we are doing is country support. And that we are linking to specific diseases. We have mainly been working with Roma populations when it comes to vaccine uptake. And the way that we are working there is working both with the national authorities and with Roma NGOs, trying to get toolkits, communication toolkits. We have one guide called Let's Talk About Protection that has been translated and culturally adapted. It has been used in Bulgaria and in other countries, and after testing we would like to disseminate it further. So this is basically the way that we are working. Data, facts, and then pilot interventions.
Pascal, you were worrying, and then so was Isabel earlier, about collecting data disaggregated by ethnic groups and so on has some elements of discrimination. You were saying that you had problems with the Roma population data, Isabel?
Yeah, we have problems.
Could you explain that a bit more about the complexities to, maybe you haven't thought about that, sort of the one-to-one presence from Santa?
I mean, from the scientific point of view, and in a previous life I was epidemiologist, for sure that you need to have data and for all the variables, and that will be a dream to have data on gender, ethnicity, and whatever you want. A lot of, but practically, well, the data depend on the member states, and so it's a European Union regulation, but very basic. And any changes until now that we try to make in the future, in the past, sorry, fail. Because the member states have to provide that, and each new data costs money, and it's very difficult. Second, as I told before, the sensibilities, and I am going to make a small example that I told you before. We were checking the registration in one university in UK, and with someone that I know. And she was requested to fill a long questionnaire about sexual orientation, sexual identity, ethnicity, and she felt insulted because in the countries where we were living, when she has been living before, that is not possible. I mean, you cannot request the ethnicity because it's forbidden by law. You can disclose your ethnicity if you want, but by law it's forbidden. And the same for the sexual orientation and the gender identity. So it's not the same in all the European Union. It's very difficult, and I think that will be very difficult in the next year to have data on ethnicity, for example.
Very quickly, yes, because Dinekis passed by gently, looking at my eyes, saying we are running late.
To that, I mean, we have the chance to have good practices on how to basically do it in a manner that respects, people's and individuals' rights and privacy. So let's learn from those. Let's learn from the UK. Let's learn from the other places that have done it, and let's make that become a reality for better policy.
Santino, it's unfair to ask you to go very quickly on all the amount of things that INWG is doing in this area as well. Particularly the resolution in 2008 was particularly. Can you say a little bit, just very quickly?
Yeah, well, we are very heavily committed to really scale up the interaction with member states, because nowadays we are facing a region, a WHO region, with 3 different dynamics. Southern European countries with irregular migration through both people, Northern European countries with asylum-seeking integration and the issue of receiving asylum seekers, and eastern part of our region, which is almost a black hole, because a lot of information and data and also norms and laws that are still an heritage, a legacy of the past. So we are trying to put together this complexity and how assessing and evaluating the health system in country together with the Ministry of Health and other stakeholders, key partners, so Ministry of Interior, Ministry of Labor, Ministry of Education, to see how the health system is set up and how they are able to manage the issues related to public health and migration. Why that is not an evaluation. We are not evaluating situation in countries, but we are trying to set up a plan of collaboration in order to really scale up capacity and understanding of the issue, public health issues, out of the health sector, and to have the health sector able to discuss, to interact better with the other sectors. From the WHO point of view, just to conclude, because this is quite important, we realized that we need to do something in our region in order to boost the initiative of 2008, the 6117. And we have engaged, this regional committee already was the starting point. Yeah. We made a technical briefing to the member states, and we want to really go through analyzing the diversity and the political sensitivity and the specificity of the different parts of the region, and to find a common way to go about in order to have an harmonized approach and maybe to end up into a resolution and an action plan in the next future. So this is a fine and a long process, quite challenging, which is depending, of course, from the member state willingness, but WHO is there because of the Health 2020, because of the ultimate policy commitment to go
back to the public health community, back to the member states to push these organizations. I'd like you now, there have been great tweets, there have been great echoing of what's happening here, and someone is going to tweet you the final tweets. I'll ask you as a summary, one tweet to take home. I kind of warned earlier, so I hope you prepared it. If not, you can forget it. But I'll give you 30 seconds by saying I think it's a major issue, has many dimensions. Of course, we could not deal with all of them, but I think we've got many key ones. Carl, you want to start?
Yes.
It has to be in a way of a tweet.
So the background to my tweet is that many of the migrants are getting infected after they are coming. So the tweet sounds, a pledge to decision makers to ensure that policy and program implementation is being based on solid facts, not on myths.
Very nice, thank you. Isabel, you want a bit more time?
I didn't write the tweet, but something like that. Intersectoriality is important. Preaching to the converted is of no value. We have to talk to the others that are not so convinced of the value of working with migrants.
We have the Minister of Interior, Police, and many others of Finance here to deal with migration.
Almost on the same line, based on the experience, when the Ministry of Health developed understanding that they have a role, they have a stake into the process, and they're engaging into interacting with other non-health sector, success is behind the corner.
Thank you.
I wish it had come up already. Communities are not an obstacle on path to reducing health inequality. They are the path to reducing health inequality.
Oh, nice.
Right,
you get the last word, the first word, the last word today.
working on these inequalities improves the health of everyone and makes the world and Europe a better place.
Yeah,
exactly.
Here, here.
It's not about being nice, but it makes a better place. And it's good for the economy. I believe that as well. It's good for the economy. Well, can you please thank these wonderful speakers? And thank you very much.
It was so nice to meet you.
We've found a hat, so please come and claim it before it's handed out as a prize. I can't remember whether I've mentioned it or not, but we had a record number of people here in Glasgow. I'm not sure whether we quite hit 1,600, but we're very close. We had a record number of abstracts submitted, and I think as a result of that, the science here has been of excellent quality, the little I've had time to see. But whilst a lot of you were at the science yesterday, there was some public engagement going on with our first ever coffee shop conferences. An intrepid bunch set off on bicycles, cycled along the Clyde to the magnificent People's Palace and the Winter Gardens there, where they delivered to the public two conferences, mini conferences, researchers from the conference led by expert moderators about obesity and about staying active. This seemed to be a very popular event. It went down well with the people there, and it is something that UFO will continue to do in the future. So I'd like to thank all those people involved in making this a very successful venture. Chris Burt and Nanette Mutri, the moderators, but also Aina Bond, Cindy Gray, Modi Mwatsama, and Tom McBain. Thank you very much. This leads to a string of thanks, so please don't clap them all, otherwise we'll be here till Milan. The European Public Health Conference Office have, as always, done a magnificent job just making sure everything goes as it should. We've had wonderful hosts from the City of Glasgow College. We've had help and support from the exhibition centre itself. Organisation of the conference, I'd say, has been about 1% fun and 99% hard work. My advice to Carlo is to do what I did, and that's get other people to do the hard work, and you just have the fun. I've had a huge amount of support from colleagues, so many of them that I'm afraid to name them, because if I do, I'll miss some out. But the things they've been doing, the help with the exhibition stand, the quiz, the background organisation, but imagine what it takes to stuff 1,500 conference bags with all the material you've got. I wasn't very popular that day. But one person I would name is Patricia Fisher, who has, if nothing else, kept me sane through the past few weeks, I think. And she has been a great support to me. She's not here at the moment. She has taken a well-earned holiday. Prizes. The highest scoring abstract of the conference, with a breathtaking 4.8 out of 5 average, goes to Aaron Reeves from the Department of Sociology at the University of Oxford. His abstract was Social Protection and Tuberculosis Control, Cross-National Analysis of 21 EU countries, 1995 to 2012. Is Aaron here? Well, Aaron wins a waiver of the conference fee for next year's conference. We have the Ferenc Boyan Young Investigator Award, which goes to Cécile Vuillermoz from Anselme for her abstract, her presentation on cervical and breast cancer screening among homeless women with children in the Paris area. Is Cécile here? Oh, well, maybe we'll recycle these. This is another waiver of fees for next year's conference. Perhaps I'll keep these. Oh, great. We have posters. In third place, we have a poster by Parente and colleagues from the Catholic University of the Sacred Heart for the poster, The Mob Health. I'm afraid you don't get a conference waiver, but you do get one of these most talked after fashion accessories. In second place, we have a poster by Quercioli and colleagues from the local health authority 7 of Tuscany region, Siena. The poster was objective or perceived health measure, which is a best cost predictor. And the winner was Anastasi and colleagues from University of Cassino and Southern Lazio for their poster, Live and Let Die, Do James Bond's Movies Reflect Smoking and Drinking Population Patterns? And this one does come with a conference waiver for next year, as well as the fantastic scarf. Now, on the subject of magnificent prizes, we have the quiz. And does anyone remember Gothenburg in 1998? I'd like to make a call to go back to bags that we can reuse. These are fantastic. I still use it. We have 2 prizes for the quiz going to Sophie Duro-Payard and to Ursula Berger. Since you seem to be the only one here, you can have the choice, and we'll contact Sophie later. I know the quiz was a little taxing for some people. We had 54 entries, but we did raise an excellent £185. So thank you all very much. I think that is my part finished. Have I forgotten anything? In which case, I'd like to invite Martin McKee to come up on stage. Martin.
Thank you very much, Alistair. So, 25 years ago, a very bright and enthusiastic young Italian student came to the London school when I was teaching, and I'd done the master's degree there a few years earlier. And it was really obvious to us that this was somebody that was going to go far. How far, none of us could have imagined. And of course, I'm talking about our former president, our immediate past president, Walter Ricciardi. I'm not going to say very much because you will see in the next edition of the European Journal a full tribute to his many, many achievements, just simply to say that he has done more than anyone could possibly imagine to support the development of UFA. When he took over the presidency, he did so when we were going through very difficult times. He's the longest serving president ever, having agreed to stay on for 2 terms, and he really has done so much for Italian public health, for European public health, and actually for world public health. So Walter, can I ask you to come up, and we would like to make a small presentation to you. It is a huge pleasure. And well, when you unwrap it, you will see, but it has links to public health and links to Glasgow. Thank you.
Thank you very much. Thank you very much. I'm very proud to be a member of this fantastic community. I think we have achieved a lot and we will do a lot. But now it's time for me. I was asked to thank, and from the deep of my heart, I want to thank, first of all, Alistair. And I was told by Dineke that all breakers were broken, and dear Alistair, a huge thank you for all of your work. You broke all records and kept your Scottish calm and wit. So I thank you on behalf of all our community, because I think Glasgow was really one of the best times of our lives, and thank you very much for this. Please come and take it. And of course, you and thanking Alistair, I thank all the people in his staff that have made a marvelous job. And I also want to thank another very important person, is Pat. Dear Pat, a big thank you for the wonderful collaboration. It was a real pleasure working with you. So please thank you and all your staff. And now I've been asked to summarize Mission Impossible, this fantastic conference. And I really am happy that researchers, educators, policymakers, practitioners, community representatives, and health managers from Europe and beyond shared in these days new information and insights from their experiences with the interventions to reduce health inequalities, the theme of our conference, and develop a deeper understanding of the urgency to address this issue. And the final fantastic plenary has confirmed this.
This conference is about promoting excellence in public health in Europe. Europe is a tremendous powerhouse of research, but sometimes in public health we don't achieve as much as we might do. This is an opportunity to celebrate our successes and to bring everyone up to the level of the best. And it's a great opportunity for networking, to bring people together, to exchange ideas on good practice, on good ideas for research and collaboration, and really to make the world a better place.
What do we know about what works to reduce inequalities in health?
Trends in health inequalities are more encouraging than commonly thought. Thank you.
Whether they just seem to be enablers maybe to do their job. And we just also try to identify in enabling and
And I'm still impressed by the title of this conference, Please Mind the Gap.
If we work together, I think we can succeed in the future. Thank you very much.
So these were, of course, the main messages, but of course there are many others. And the facts are that health inequalities are a persistent problem in European countries. Although health in Europe has improved in recent decades, inequalities in health have also widened. Health inequalities refer to difference in people's health and life chances. Health inequalities are strongly related to the condition in which people live, such as their income or the area they reside in. Health inequalities exist not only between countries, but also within countries, and crucially, they are still increasing in many places. The evidence that you have presented at the European Public Conference in Glasgow has been overwhelming. So the research shows that it's possible to do something, that there are good examples on how to deal with studies. We have seen some of them. And even though successes have been made, the focus should be on reduction, and Johan Mackenbach's sake, of relative but also absolute risk of health inequalities, not improvement in specific population groups of areas. And what Marine and Reggie said this afternoon has been incredibly inspirational for this. The lessons is that we have to work in system. The modern approach to public health has broken down barrier after barrier, separating different functions, disciplines, fields, and sectors. In silos, we are weak. Together in a system, we are one of the strongest power in the world. But to create a system to work systematically means understanding, working together, bridging the gap even between communicable and non-communicable disease, forging a convergent approach from an integrated public health perspective. So at the end of the day, we have to persuade our government, our stakeholders, that governance for health will require the whole of society and the whole of government responsibility and mechanism, effective ministries of health, modern public health infrastructures, robust health systems, and new articulations and advocacy for health. And I would like to emphasize the fact that the video that you saw was produced by Dr. Elena Azzolini, who was the awardee of the Postel Prize last year. And in these years, from Siena to Rome, he has become a public health media specialist that was just shot here on the ground. So we are going to produce a Glasgow Declaration, as in other conferences, in particular the Granada Declaration has been mentioned. All hands on deck to close the health inequalities gap. We need to do better research. We need not only more data, but also studies on how to achieve population-wide impact. We need research evidence to policy consistently and at all levels. We have to understand what works to reduce health inequalities, for whom and why. Work with policymakers to improve the evaluation of the health impacts of policies and large-scale interventions. Best practice is change. Some issues that have been repeatedly mentioned during the plenary, during the panel, during the parallel. And we have to think outside the box. Sometimes, particularly we, the researchers, are focused on our topic. We have to open the box and include other topics in our activity. And foster public engagement, as Alistair has shared this afternoon, example of rugby, clubs, schools, solidarity, increase personal engagement. This is time where you have to stand up and speak up for the people that cannot have a voice, and to develop the commitment of the public health communities, obtain a commitment from the community, because in some plenary we have told we have to engage citizens more, we have to be able to speak with them. Some years ago, you may remember, Jonathan Lomas and Martin McKee showed a cartoon that I've widely disseminated in these years in Europe. They showed some people on a balloon, and one of them asked, "Where am I?" And the fisherman replies, "You are 30 meters up in a balloon." And the person said, "You must be a researcher." And say, "Yeah, but how did you know?" "Because you gave me a very accurate but totally irrelevant answer." That was essentially the reply of the people on the balloon. But the fisherman saying, "You must be a politician." "Yeah, but how did you know?" "Because you don't know where you are, you don't know where you are going, you are blaming me for all this mess." That's what was said. I believe that with this conference we have changed the cartoon this way. Where am I? You are traveling in Europe trying to reduce health inequalities in a generation. You must be a researcher. "Yeah, but how did you know?" "Because you gave me a very accurate and useful information." "And you must be a new politician." "Yeah, but how did you know?" "Because you are working for future generation and not for next elections." And that is the result of our work.
Well, I hope you really enjoyed the networking facilities at this conference in Glasgow, and of course next year in Milan we'll have it again.
And you have seen a very important person that has been working in all these years, and I really want now to hand over to Professor Signorelli. But as most of us have said in the letter to Santa Claus, we are not sleeping. We are watching what is going on in next year. And at the 8th European Public Health Conference in October 2015 in Milan, we will evaluate how far Europe has put in place policies that can reduce health inequalities. And we encourage all of you, because now we have in our constituency researchers, practitioners, educators, governments, NGOs, and funders to contribute towards that vision. Thank you very much, and thank you very much for all. Carlo.
Thank you very much, Walter, and I have the honor and the pleasure of closing this conference by presenting the next European Public Health Conference to be held in Milan from 14 to 17 of October 2015. The next conference will be held in conjunction with the 48th National Congress of the Italian Society of Hygiene, Preventive Medicine and Public Health, with which I have the honor of chairing since last month. Although this may be known of some of you, please allow me to spend a few words to introduce to you our association, that is the scientific society of about 3,000 members that has historically contributed significant to the activities of EUFA and the European Public Health Conference, and brought here in Glasgow over 100 participants with many scientific contribution and good quality contribution as seen in the prize. Scheduling the European Public Health Conference and the National Congress of the Italian Society of Hygiene in the same program is not a novelty, as it was already the case in 2003 in Rome and in 1997 in Pamplona, Spain. Yet, our member will have the opportunity to attend the European Public Health Conference session, to exchange with international peers, to learn about other experience from public health professionals and operational methods used in other European countries. The two events will take place at the new MICO Conference Center, which is one of the most modern and functional venues in Europe. We will see a video shortly. Timing will be just about perfect, as our event, as you probably know, will take place in the context of the World Expo 2015, whose main theme is feeding the planet Energy for Life. And this relates to topics that are very familiar to many of us for its public health and educational activity ramifications. Organized in the 2015 edition of the conference will be challenging, and we will take it, of course, very seriously. But we shall count on the great accessibility of Milan as a location and the incredible opportunity to be right in the spotlight of global attention. I'm sure you will agree with me that this will be an unmissable chance to experience a city known for history, art, and fashion in an atmosphere which I bet will be something out of the ordinary. We have felt during these days spent in Glasgow that there are great expectations, both from the scientific and the hospitality point of view. We will do everything to get a great reception worthy of a country with history, culture, and tradition, even in public health activities. I would now like to share with you a short video presentation of the city of Milan and the Convention Center. Thanks to all. And hope to see all of you in Milan next year. Thank you.
When all the nights that came before are finally over, I'm talking on the corner, but I know this street has a dream of its own. All the roads that I've traveled are the years from my past. But your eyes, they lie about what they've been told, until they shine like silver and gold.